and pediatric neurologists who will share their wisdom with us. This session has granted 1 MMC points. So I request all delegates to be present throughout the session. We will check the attendance at the last. Now I request respected Dr. Sanjay Joshi sir, Maharashtra IP President 2026 to address the gathering. Over to you, Joshi sir.
Am I audible?
Yes, sir.
Hello.
Yes,
Am
sir.
I
Yes,
audible?
Yes, sir.
loud
Yes.
and clear.
Yeah. Okay. So a warm welcome, as Sati has already narrated, it is the inaugural academic day. Respected seniors, colleagues, my entire team 2026, and the august audience who have joined on this virtual platform. I welcome you all. Uh, Today is the beginning of new era. Academic event, and on behalf of my team that the year will be full of academics activity. We have designed the recipe of the academic as per the need of the common pediatrician in the Maharashtra. At the outset, I express my sincere thanks to all the esteemed faculty who are from my Maharashtra team. Thank you, Dr. Vilas sir. Thank you, Vinay. Thank you, Vishu, and above all, Dr. Verma sir, who is our national coordinator of the center's AOPN. So I won't take much of the time. Friends, enjoy learning with the masters. Signing off.
Thank you, sir, for your thoughtful words and continued leadership. We are grateful for your encouragement and guidance as we begin this academic journey. Now I request MAHAIP President-elect Dr. Vinayak Patil sir to address the delegates. Sir, join झाले का? I think Vinayak Patil sir. I think sir is not there. Okay, now I request our Secretary ma'am, Dr. Renu ma'am, please address the gathering.
Yeah, good evening, one and all. And again, I wish you a New Year greeting from MAHAIP 2026 team. Good evening, respected President Sir, all the OBZBs of the CIP, MAHAIP, all the respected faculties who have joined today for the Neuro episode, and dear IPNs who have joined this meeting for our first masterclass in pediatrics. Masterclass in Pediatrics is a MAHAIP driven digital learning hub where senior experts and rising academicians in their fields from across Maharashtra will share the experience rich and evidence based strategies to improve the everyday pediatric care. And today's masterclass of epilepsy with the stalwarts in pediatric neurology. And we are very happy to have with us. And we welcome Dr. Anup Verma sir, Dr. Vilas Jadhav sir, Dr. Vineet Wankhede, and Dr. Vishwanath Kulkarni. And we will hear their experience-based mastery in pediatric epilepsy from Seizure, first Seizure to cure. And also welcome to all the online delegates again. Over to you, Sachin.
Yeah, thank you, ma'am. It's always encouraging. Now I request our MAHAIP convener, Dr. Bela ma'am, to address the gathering. Bela ma'am, join, I think.
Good
Bela ma'am.
evening, everyone.
Yeah.
Welcome to this lovely program today. And I'm very happy that Dr. Sanjeev Joshi is immediately off to the start with his scientific academic activities. And we have got these stalwarts today from whom we are going to learn a lot. So without wasting much time, I would request you to start the scientific program. Thank you so much.
Yeah. Thank you, ma'am. Dr. Prashant Jadhav sir is there? Okay. Now I request respected Dr. Ramakant sir, advisor for this masterclass in pediatrics, to address the online delegates. Ramakant sir, over to you.
Thank you, Sachin. At the outset, I will like to congratulate Dr. Sanjeev Joshi Renu, Bella Madam, Sachin, Sanjay Nathu sir, and all that starting this masterclass and wonderful idea. And it is bang on 1st of January. You had a journal club along with Raigad IAP on the day one of tenure of these office bearers. Wonderful. And on 8th, we are going to have feast of these epilepsy syndromes. We are generalists are always at the sea. What are the fires and what are the NORs and what are the different epilepsy syndromes? I think today this faculty, Dr. Anup Verma sir, Vilas Jadhav sir, Dr. Vinit, Dr. Vishwanath will decode it for us. Thank you, Sachin. And
Yeah.
I once again congratulate Maha IIP office bearer who is starting from day one for the academic activity. Over to you.
Thank you, sir, for your constant guidance. Now I request our today's MMC observer, Dr. Sagar Bhalelao, sir. Sir, unmute, sir.
Good evening, everyone, and all the best. See you.
Yeah.
Thank you.
Thank you, sir. Now I hand over the mic to Dr. Sanjay Natu, sir, for further proceedings. Over to you, Sanjay, sir.
Yes, so welcome all of you to this first master class in pediatrics, and we are going to begin with neurology. And I have the pleasure of introducing all the esteemed faculty today. So can we have the slides for the introduction of the faculty? Yes, so our faculty consists of Dr. Vishwanath Kulkarni. He is a young and dynamic pediatric neurologist from Pune and PCMC. He's completed his MD Pediatrics and IIP Fellowship in Pediatric Neurology and Epilepsy. And he's, of course, a consultant pediatric neurology and epilepsy at DY Patil Hospital, Surya Mother and Child Hospital, Aditya Mirla, and Cortex Child and Epilepsy Center. He has received several awards and presented several papers as well as talks at various conferences. So welcome, Vishwanath. Can we have the next slide?
Thank you, sir.
Yes, it's my pleasure to welcome and introduce Dr. Anup Verma, sir. Sir, as of course a senior pediatric and pediatrician and pediatric neurologist. He is from Raipur, Chhattisgarh. He has numerous publications against his name, and he has received several awards with him. So he has also delivered several affiliations, and he's of course an expert in pediatric neurology, and we are eager to hear from you, sir. So welcome, Dr. Anup Verma, sir. Next slide, please. Yeah. Next is Dr. Vilas M. Jadhav. We all are familiar with Vilas Jadhav, sir. He is adjunct professor in pediatric neurology at Dr. D.Y. Patil Hospital, Kolhapur, and also a director and consultant pediatric neurologist at Arya Children's Super Specialty Clinic, Kolhapur, and is of course the president of the Association of Pediatric Neurology Maharashtra branch. So welcome, Vilas Jadhav, sir.
Thank you, sir.
And lastly, of course, we have Dr. Vinit Wankhede, who is the National Secretary of the Academy of Pediatric Neurology and Director of the Kids Neuro Clinic, Nagpur. He is a consultant pediatric neurologist and epileptologist, and he has a lot of laurels against his name. And we are eager to hear his expert opinion at the end of this masterclass itself. So welcome, Dr. Vinit Wankhede. With this short introduction of all the faculty, we will not waste further time, and we will start with the first talk. And I'll invite Dr. Vishwanath Kulkarni to start his first talk, and he's going to speak on epilepsy syndromes. And a very important part is what the pediatrician should know about these epilepsy syndromes. So over to you, Dr. Vishwanath.
Thank you, sir. So can I share the screen?
Yes.
Yeah, is it visible?
Yes, sir.
Yes,
Yeah.
sir, it is visible and full screen. Kindly go ahead.
Thank you. At the outset, I am really thankful for my IP, Dr. Sanjay Joshi sir, Dr. Renu ma'am, Dr. Sachin, Dr. Ramakant sir, Dr. Nathu sir, Vilas Jadhav sir, Vinit, and Anup sir for giving this opportunity to present this particular talk on epilepsy syndromes. Now, without wasting time, I would like to finish my particular topic in the military precision. So what is epilepsy syndrome? We know about seizure, we know about epilepsy, correct? So seizure is the excessive abnormal electrical activity of the brain that all of us know. So either these seizures are provoked or unprovoked. Correct? So provoked means it is provoked by fever, by trauma, by dyselectrolytemia. It does not constitute epilepsy. What is epilepsy? Epilepsy constitutes two unprovoked seizures at 24 hours apart, or one unprovoked seizure having recurrence risk to be almost 60% within the next 5 years. That is epilepsy. Now, as a pediatrician, what is epilepsy syndrome? Whether it is something new? Answer is not. It is not very new. So epilepsy, that is ILAE, International League Against Epilepsy, has come up with the definition of epilepsy syndrome, and will evolve this epilepsy syndrome over the next few slides. So coming to the definition. So it is a characteristic cluster of clinical and EEG features. So EEG features are very important when you talk about epilepsy syndromes, often supported by specific etiological findings. Those are either structural, genetic, metabolic, immune, or infections. So the why diagnosis of epilepsy syndrome is important, because it is having immense prognostic and treatment implications. These syndromes are generally age dependent. Now, what ILA did, ILA classified these particular syndromes into 4 variants. Number 1, syndromes with onset in neonate and infantile age group. Syndromes that say having onset in the childhood age group, and syndromes that may begin at variable age, meaning in both pediatric as well as adult patients. And the fourth one, additionally, the fourth position paper, which ILA came up in 2000 from 21 to 22, and now they are having also one, the guidelines recommendation in 2025. So fourth position paper was on idiopathic generalized epilepsies, that is been included. Yeah, now this slide, now you must be, surprised why I'm putting this Nandi in front of the Shiva's temple. So the way we first take darshan of Nandi and go to Shiva, we cannot go to epilepsy syndromes without learning this slide. And you are supposed to by heart this particular slide. Okay. So what it says, if you say the first one is the seizure type, either it is a focal seizure, generalized seizure, or unknown seizure, when you unable to, don't know the semiology. Once you are said the seizures are unprovoked, then go to the epilepsy type, whether it is focal epilepsy, generalized epilepsy, combined generalized and focal epilepsy, or again unknown subgroup. And once you are sure what is the epilepsy type, then try to fit that particular epilepsy into epilepsy syndrome. Okay. On the right hand side, there are the etiologies: structural, genetic, infection, metabolic, immune, unknown. And on the left hand side, associated comorbidities. Because epilepsy and epilepsy syndrome, they don't come like that only. They come with some comorbidities like learning difficulties and so. So let's start with syndromes with onset in the neonate and infants. Now again, if you see this particular cartoon, this is by ILE. There are 3 boxes. The first one is self-limited epilepsies, and they consider self-limited neonatal epilepsy, self-limited familial neonatal infantile epilepsy, self-limited infantile epilepsy. So you can shortly call SELNI, SELFNI, and SELI. Other are the genetic epilepsy with febrile seizures and myoclonic epilepsy of infancy. So these are the self-limited epilepsy syndromes. So these are likely to be very benign one. Coming to the developmental and epileptic encephalopathies, these are likely to be very severe one. So in this one, you get early infantile developmental and epileptic encephalopathy, epilepsy in infancy with migrating focal seizures, infantile epileptic spasm syndromes. We know about the West syndrome and Dravet syndrome. This is a channelopathy. And etiology specific syndromes, those are now this is the era of genes, and we are going to hit the genes. And once you know the gene, you can put that particular epilepsy syndrome, whether it is KCNQ2 epilepsy, whether it is pyridoxine dependent epilepsy, whether it is CDKL5 epilepsy, whether it is PCH19 epilepsy, and so on. So I will take one prototype of example. So let's come to the self-limited epilepsies, and that to the self-limited neonatal epilepsy. So the seizures typically start between day 2 to day 7 of life, and often are focal tonic or focal clonic features, or may progress to have sequential features. Focal seizures may alternate sides from seizure to seizure. Seizure can recur over hours or days, and developmental milestones are usually normal. So that is the beauty of this self-limited neonatal epilepsy. EEG, generally the background of the EEG is normal, or you may get some slow, minor, non-specific abnormalities like centrotemporals, sharps and spikes. Neuroimaging is generally normal. So that this is the prototype of self-limited neonatal seizure. Coming to the genetics, so in these self-limiting neonatal seizures also, you can get few genes like KCNQ2 and KCNQ3. Coming to the second box, that is the devastating one, developmental epileptic encephalopathies. We'll talk about early infantile developmental and epileptic encephalopathy. So what is different in this particular? So onset of the epilepsy in the first 3 months of the life with frequent seizures that are typically drug resistance. So number one, there should be frequencies increased, the drug resistance is increased. You can get abnormal neurological findings, abnormality in posture, tone and movement. And there is moderate to profound developmental impairment evident with the time in this particular group. Invariably, you can get the abnormal EEG, you can get the burst suppression pattern. And with the advent of neuroimaging, metabolic and genetic testing, your precise etiological classification you can do in almost 80% of the kids having this EIDEE. If say we send this particular infant to the imaging, so you can get structural brain abnormalities. And when the seizures are drug resistant and focal seizures are prominent, further imaging modality should be considered like PET scan and SPECT scan to exclude a surgically remediable lesion. For certain genetic etiologies, imaging is often normal initially or may show reduced brain volume, that is the cortical atrophy, or the cortical atrophy may evident over the period of time. Sometimes you can get white matter changes like hypo and dysmyelination too. So the genetics, which are genetics tests to be considered in this, like microarray, where you can get chromosome 20 abnormality, or you can say whole exome sequencing, as well as you can think about whole genome sequencing also. So let's talk about a case. He is a 6-month-old male child. He came with abnormal movements of the body in clusters after waking up from the sleep. He lost the achieved social smile, that is, there is neuroregression. Mobile video, which is very important nowadays, was done by the parents. He was born by non-consanguinity, near term. He was small for gestational age. Weight was 1.9 kg. On day 2, he developed lethargy. Now, this scenario you can get the SJ baby 1.9 kg. So this is the child having, say, hypoglycemia. Blood sugar level was 20 milligram per deciliter and sepsis screen was positive. So can you see? Yeah, it is not opening, but it is typical spasm, flexor spasm. The child was flexing the arms, and there is flexion of the trunk also. The salam attacks, what we term. So what is your impression? So this is the infantile spasm, correct? Further investigations? Yes, definitely. Infantile spasms, there should be the triad. What is the triad? There should be the spasms, correct? There should be neuroregression and there should be the abnormal EEG. So we got the EEG and EEG is showing utterly chaotic pattern. That is the high amplitude spike and slow waves, if you can see. So this is the modified burst, modified Hips arrhythmia pattern. This is the burst and there is little separation over here. MRI brain, you can find there is bilateral involvement of the parieto-occipital regions, which typically happens in neonatal hypoglycemic brain injuries. So now diagnosing epileptic syndrome at this age is very important as far as the pediatrician is concerned because it is a medical emergency. You have to start the child on steroids as well as vigabatrin. Now the recent studies, they show there is improved outcome when you start steroids plus vigabatrin. So that is importance of identifying the epileptic syndrome at earliest. Now from this infant age, now we'll go to little childhood. And if you see this particular cartoon again by the ILE, so this is the spectrum of selfies. self-limited focal epilepsies in pediatric age group. So either these are celias, like self-limited epilepsy with autonomic seizures, or selects. The hysteria term was Rolandic or Beck's. Cough and pole, childhood onset visual epilepsy and pole epilepsy. So what is the basic criteria when you can diagnose as a pediatrician? Number one, age dependent occurrence generally occur after 3 years of age, 3-4 years. The antecedent history is usually unremarkable. Cognition and neurological examination often normal. Now these epilepsies, they generally remit by the age of puberty. They are having classical seizure semiology and they are having specific EEG features. We will discuss. Correct? We have already discussed this. These are age dependent, birth history normal, remission occurs, genetic predisposition for the EEG trait, classic seizure semiology for E syndrome. Now let's see the case. He's a 6 years old male child. He brought with one episode of seizure while asleep. There was deviation of angle of mouth towards one side, followed by focal tonic-clonic movements of right upper lower limbs associated with gurgling sounds, lasting for a few minutes, followed by post-ictal drowsiness for 2 hours. There were no previous episodes. His birth and developmental history was otherwise normal. What is the impression? Yeah, you may say this is Rolandic, this is Beck's. The recent terminology is select, self-limiting epilepsy with centrotemporal spikes. So what is the further investigation? We got the classical semiology. There was gurgling sound. It was, say, diurnal variation. You can get diurnal or these seizures, they occur during sleep only. And this is the EEG. However, this was the awake EEG. Whenever you are getting any child having seizure during sleep, ask for specific sleep EEG. And then we got the sleep EEG and you are getting the bilateral centrotemporal discharges. So this child is fulfilling all the criteria of select. What is the management? Generally, isolated seizures you do not treat also. However, this child was treated and given oxcarb, and then he came with cognitive decline over the period of time. Otherwise, normal child. So, what you would like to do? So, whenever a child with select or this focal epilepsies, you start him on medication, and the child comes with a cognitive decline or developmental regression, get another EEG, and if you see there are continuous high amplitude generalized spike and slow wave discharges. So EEG got worsened after starting the oxcarbazepine. So whether to change the anti-seizure medication over here? Answer is yes. You have to stop oxcarb. You have to start little broad spectrum anti-seizure medication like valproate. And here comes the another syndrome, which is called epileptic encephalopathy or developmental epileptic encephalopathy with spike wave activation in sleep, that is EE-SWAS or DEE-SWAS, what we term them. So when there is no developmental epileptic encephalopathy, the last slide of EEG we saw, that is the epileptic encephalopathy. No DE, either those are selects, celias, cough, and when there is encephalopathy, then either it is Landau-Kleffner syndrome or encephalopathy with continuous spike and slow wave discharges during sleep. Okay, so we have talked about this benign epilepsy syndromes. Now let's come to this 7-year-old female child who brought with recurrent episodes of motor arrest lasting for a few seconds since 2 months. Birth development was normal, normal neurological examination. So whenever you come across with such a child, की ओपीडी मध्ये ते शी जस्ट शून्यामध्ये जाते, थोड्या वेळासाठी जाते, typically you come to know these are looking like abscences. But again, childhood abscence is a syndrome. There should be characteristic signature for the same. What are the probabilities? Any clinical handle in the OPD practice can it? Yeah, you ask the child to hyperventilate for 3 minutes and then you can get the motor arrest. This is the clinical handle you can definitely use in your clinical practice. So coming to the EEG, this is again a classical Rangoli type 3 Hz spike and slow wave pattern, which you typically get in the absence epilepsies. Whether there is role of MRI in typical absence, there is no role. How will you manage? You can start on ethosuximide or valproate. Correct? Now, this is again classification. This is very important. Remember this. So, the umbrella term is genetic generalized epilepsy. Under GE, these are the IGs. Either it is childhood absence epilepsy, juvenile onset, depending upon the age of the onset, which we have already seen in our first slide. Or juvenile myoclonic epilepsy. Here, the semiology changed from absence to the myoclonus. The sudden jerk-like, activity the child can do. And epilepsy with generalized tonic-clonic seizure or GTC alone. That is one. And those generalized seizures which are having epileptic encephalopathy, so these are epilepsy with myoclonic atonic seizure, which was yesterday called DO syndrome, epilepsy with eyelid myoclonia, which was termed as Gibbon syndrome, epilepsy with myoclonic absences, Tassinari syndrome. So those are all having epileptic encephalopathies. Okay. So this is very important. Now, this must be my last slide when I talked about the infantile onset syndromes, childhood onset self-limiting syndromes, and the generalized syndromes. My take home to pediatricians will be think syndromes, just not seizures. Seizure disorder can't be your diagnosis. You have to think about syndromes because it guides prognosis, investigation, treatment, and counseling. Like in a child with focal epilepsy, you can tell not to worry. This can be one of the episode which child might get in 6 months to 1 year. It is called select. Don't worry. Correct? Age of onset is the strongest clue for the epilepsy syndromes. It is very important to, I can say, semiology. If you know the semiology plus EEG, it is directly leads to the diagnosis, and we are all diagnosticians. Not all epilepsies are lifelong. They can be remitted at particular age. Some syndromes are epileptic encephalopathies, then your prognosis completely changes, your treatment changes. Treatment must be syndrome specific. Like in say West syndrome, you have to give broad spectrum anti-epileptic anti-seizure medications. Development and cognition definitely matter for that child, for that family, for everyone in the society. Genetics is increasingly important, so you have to keep your threshold low to think about the genetic epilepsies. Early onset, developmental regression, refractory seizures, or atypical features. These are the red flags to refer these children as early as possible to your pediatric neurologist, and you can counsel families very early and honestly. Thank you. Thank you once again.
Thank you, Dr. Vishwanath, for shedding light on these epilepsy syndromes. And it's quite a detailed discussion which you had on this topic. So thank you. If anyone has any questions, they can put in the chat box and we can take them at the end. We will proceed further with the second talk for today's session. And I request Dr. Anup Verma sir to take over the presentation. And he's going to talk on a very important topic, that is seizure mimics. So, Dr. Anup Verma, sir. Dr. Anup, sir, you can share your screen.
Yeah. Am I audible, sir?
Yes, sir.
Yes,
Okay.
sir.
Dignitaries on the dais, and it really gives me a very immense pleasure and a sense of privilege to be a part of this august academic gathering, the Masterclass in Pediatrics, the episode number 1 of MAHA-IAP, a truly commendable initiative aimed at strengthening the practical pediatric learning. I extend my heartfelt congratulations to my dear friend Dr. Sanjeev Joshi, the newly installed state president of Maharashtra, the largest state of our country. A dynamic leader, a 2 times executive board member, and the past national chair of AOPN, Dr. Joshi has always been a passionate academician and a friend with whom it has been a real pleasure to work. His commitment to pediatric education and organizational excellence continues to inspire many of us. I would like also to acknowledge the invaluable academic leadership of Dr. Sanjay Nath as a scientific chair and Sachin Patil as a co-chair, and almost all dear friends on this stage, whose vision has shaped this excellent master class. My sincere regards to all the respected dignitaries on the dais and the organizing team for curating such a focused and clinical relevant program. Thank you once again. I just wish to share my slide. It is not visible. Is it visible, sir?
Yes, sir. Please make it full
Is it
screen.
visible, sir?
Yes,
Yes,
sir.
sir. Just make it in the presentation mode.
Yes, I'm not getting the presentation mode. Is it okay, sir?
Yes, sir.
So, friends, you must be amazed that what is this for? Most of we are thinking that he is a Amitabh Bachchan and he is singing his typical style and all. So there is a uncanny resemblance with most of the stars. There are so many people has a uncanny resemblance, and they take the advantage. And here is our duty to distinguish or differentiate these clinical chameleons from the real disorders. So So here comes the mimics of the seizure, the clinical pulse and the pitfalls. We would like to differentiate clinically with minimal investigation. We will not talk on the treatment part, but definitely this is a video-rich presentation. And most of comes in the OPD, and probably everybody has witnessed such type of clinical cases. So here you are seeing a patient. He's in front of you in clinical in your OPD. You know, he was being referred as a case of epilepsy, and he was already on Levipil, the video number 1 on the left side. He was not responding. And the same case just 3 days back, this is a different patient. The video number B, almost similar sort of presentation. So is it an epileptic episode or is it a non-epileptic episode? Just say that he presented with behavioral arrest accompanied by a complicated behavior which appears to be a complex partial seizure. So do you think this is a epilepsy or a non-epileptic condition? Here is a patient came very late in night and came in a similar sort of the jerks considered was in the patient was in a status, kept on levetiracetam, but there was no response. We will explore more. Just see the video and have your own interpretation. Apprehensive parents, a lot of rush was there, brought this child in the busy OPD doing such type of clonic jerks and looking to the you can call it a semiology or the phenomenology. Is it a seizure or a non-epileptic condition? Frequent lapses of awareness noted by the teacher of this female patient, and the parents attributed that she is very good in academics and it was a good student. And upon during this lapses of the consciousness, the patient didn't respond. That was a good indicator for a diagnosis. So do you think this is a epilepsy, or if it is an epilepsy, what sort of epilepsy it is? So this is have to differentiate. You see this is a patient, such type of severe clonic jerks and abnormal head movement. Do you think, looking to the video, is it fitting in to some semiology of a seizure disorder? 7 days neonate referred for admission in NICU, considering to be a classical neonatal seizure episode. The thing was, the seizure never appeared when the child was awake, only during this sleep. Junior resident informed the presence of this focal seizure. Junior resident informed the presence of this focal seizure in this neonate, and upon holding the head, the seizure used to abort. So do you think that this is a classical case, or if not classical, a case of some sort of seizure disorder? Yeah. So this is sort of a mind mapping. These are the rich clinical sources. If we are prepared, our mind is prepared in OPD, that this type of abnormal movement I consider to be as a epilepsy, or it is not fitting into the epilepsy and it is a mimic sort of thing. So mind mapping is very, very important. The mind holds the map and the eyes obey. If you are tuned, if you are prepared to pick up, it will never miss, and we will focus even the history will be very focused, our examination will be very focused and very pinpointed. Now, this is how to go about this why diagnose the seizure maybe. Avoid misdiagnosis. 20 to 30% patient who comes in epilepsy clinic, which is said to be not responding to treatment, what said of the resistant sort of condition, it belongs to this group. So we have to prevent unnecessary loading the system of this child who didn't have a seizure disorder. We should have a targeted management. Parental anxiety has to be reduced and optimal resources to be exhausted. So to treat with care, to act with thought, the mimic must be known. Only then the child is safe and the right path clearly shown. So the spectrum of seizure mimic in children, we know that it can be physiological, it can be behavioral, it can be reflex, movement disorder, and sleep related and psychological. They all, you name a seizure, there is a mimic. So that has to be taken. After an excellent talk by Dr. Vishwanath, you can see that every syndrome, what she has said, has a mimic of that. So if we consider the different sort of types of seizure, the contribution of sleep disorder is to the tune of 35%. Syncope contributes to 30% in the seizure mimic, and clonic movements 10%, and PNS is 10%. Daydreaming is 15%. So this is a age-related or age-based approach. You can see that this is from 0 to 6 months. You can have this presentation. From 6 months to 1 year, you can have all sort of stereotypy, benign paroxysmal vertigo like that. From 4 years onwards, you can have tic and slightly similar to that. So this is just a age-based approach to it. So what we intend to do is, first, the art of history taking is very, very, very important, and to display the spectrum of seizure mimic and approach to diagnosis. So coming to a very important area, the diagnostic pillar of any case of, you may call it a seizure or mimic. History, very important. Prodrome, context, and triggers important. As you are seeing that the table, which is having a 4 legs, and HEIH is very important. And this presentation will take you this EHI in every case. Home video, excellently, very important, very important. Examination and investigation do contribute, but what we are doing is we are more focused on examination. We are more focused, or rather maximally focused on the investigation. But the thing is, what we will see that, you see, this is a very important, 60% times the history is going to assist you in diagnosis, 60% time. 20% home videos. Nowadays, the patients comes with home video. Then we started practice somewhere in 89 and 91. We don't have such type of facility. We have to call the videographer with a huge sort of video camera from the video parlor and take the like that. So this is at 20% home video and 10% examination and 10% investigation. That is very important. So this is why history matters. You can taking history is a starting point in making the diagnosis. You can see that almost 60% time your approach to diagnosis will be perfect if the history is correct. Then you can see, allow plenty of time. Listen to the child as much as the parents. Be imaginative and find the eyewitness. That is very, very important to pick up the eye. The art of history taking turns whisper into clarity. That is important. Now you can see the importance of home video recording. It is very important. Everybody is aware of when to take a video and all. So we have to ask the parents and to take the video whenever they feel that there is something abnormal in the patient. It contributes to 20%. If the history is correct and video is in front of you, you are near to the diagnosis 80% of times. So the camera never lies. Camera never lies. It shows what the eye may have missed. That is very important. So this is a general way of differentiating epileptic abnormal movement and mimics. Precipitants can be there, none and in epilepsy. Onset and offset is sudden in epilepsy. Duration may from seconds to minute. Post-ictal may be confused or sleepy and like that. Similarly, mimics are. You can see the mimics as well. That. So the 12-year-old child, he fainted after schooling. And this is the common scenario every pediatrician must have faced coming from the child is brought by the teachers in the OPD. साहब ये तो गिर गया बेहोश हो गया कुछ बोल नहीं रहा है खड़ा था बहुत देर तक प्रेयर में खड़ा था so this is a routine problem. So a child, if the face turns white before the fall, probably we are dealing with the case of syncope. So I have brought this small video for you. This I have prepared. This is 1.5 minutes. So this was prepared because we have never seen or we have never seen the video of a patient who is standing in the prayer and falling. So this way, just to differentiate how we can immediately come to a conclusion that this is a syncope or this is a sort of epileptic event. So this is again a patient, 6-year-old girl, staring blankly in the class, fully responsive, resumes activity and respond immediately. Teacher suspects some problem. History, home video, examination, HHEAI, again very important. Is it an epilepsy or a non-epilepsy? Definitely look into this, but he responds immediately. The age group, this is a classical case of daydreaming. So the eye may wander, but the awareness stays near. In the absence, both sight and sense disappear. This is a very classical difference clinically. And you can see the daydreaming, common in school age group, gradual onset, variable duration, responsiveness is always there as we differentiate its counter epileptic part, that is the childhood absence. The patient may be fully aware and can recall the thoughts and the daydream. So EEG is always normal. So this is how, and this is all the videos taken from the YouTube, just to explain you more better the daydreaming and it is counterpart, the childhood absence epilepsy, and here it is. A child who is presented with the repeated behavioral arrest, this you can see the behavioral arrest in front of me. This is definitely, we have to clarify this is episode is epilepsy or a non-epileptic. So what we'll have to do is ask the patient to hyperventilate and it will be precipitated if it is a childhood absence. So a video is worth 1,000 EEG. You can see the child is hyperventilating. This is hyperventilating, and you can see the way the EEG is coming. 3 spikes and wave. So this is a classical presentation of childhood absence epilepsy, and hyperventilation for 3 minutes usually makes the diagnosis almost very, very clear, and you have to order EEG for confirmation. Another patient you are seeing, 6-year-old female with sudden rhythmic jerking of the right arm lasting for about 45 seconds, no preceding injury, or there is no loss of consciousness as you are seeing is opaque. So this was a clonic sort of seizure, and the limb was having a weak up for a few minutes after this. So this was a TOTS paresis. We don't expect any sort of weakness in mimics. So definitely this is the classical of a clonic sort of focal clonic seizure. It is an epileptic event. So when the rhythm rules one side, the cortex tells it tail. You can say the clonic epileptic events are rhythmic, as if some music is going on, stereotypic. Whereas if it is a non-rhythmic, it is a non-epileptic one. So if it is a non-epileptic clonic sort of seizure which mimic the clonic epilepsy, it could be syncope, it could be a reflex, breath holding the spell, cardiac syncope, and psychogenic. There are 2 videos. One is non-epileptic. You have to make a diagnosis. What the number 1 video is the patient is exhibiting, and the second one you can see. The right one is having a right-sided facial musculature in the spasm, sort of a heavy facial sort of a spasm is there. And the second one is, see the CT scan, the granuloma was there, and this is a right focal motor event. Another patient, you can see the second number video, the clonic sort of event is there, almost mimicking like the video number 1, but this was different. This is a classical presentation of neurocystic sarcosis, and you can see the neuroimaging correlate of this event. So you have to differentiate accordingly. Another patient, you can see number 1 video is almost mimicking the abnormal movement by the video number 2. This was, yes, you can see the twitchings and of the right half of the face last 1 year disappears during sleep. This was a classical chronic motor. Tick was there mimicking an epileptic event. And in fact, when he came to us, he was already on anti-epileptic drug. So you have to the same, the way this is a classical presentation of psychogenic event. And in this event, if you order a patient that start your seizure, he will start. Now you can stop the seizure, he will stop. So the patient has already started the seizure upon, you can see it. Yeah. He has started the seizure. Now stop. Now you can see. Here he has stopped the seizure. So this is a classic. Another, the same sort of age group and same sort of movement. Both are different. Almost this patient I just seen a week back only. So this is a classical psychogenic event. Another patient apprehensive, brought with the child. This is a classical way of the presentation of the psychogenic origin. Another patient, you can see we have already given he was already on the levetiracetam, and see the milestones recently regressed. See the head holding in this patient, acute onset, totally breastfed. See and upon treatment, on the vitamin B12, the patient, you can see now he is sitting well, having a good tone. This is a classical of ITS. A trembling child with fading hues tells the like that. You can see the another patient, video number 2. You can see the focal event is there, clonic sort of movement is there. Now see the face of the child. Yeah, but port while stain or stain is there, and you can MRI can see the the meningeal enhancement over the parieto-occipital region. So this was a case of Sturge-Weber syndrome, mimicking like similar sort of ITS the child is doing. See the video number 2, the newborn in the nursery, right? Focal motor seizure is there. You can see, and you can see the MRI hyper intensities in the basal ganglia, case of herpes simplex encephalitis, an epileptic event. Another patient, there are 2 of the similar age group. Video number 1, see the video number 2. Video number 2 patient described that he was suffering from ARI, got the this medicine given. We all use bronchodilator drops, and basically due to the drug high doses of the drug given to this patient, there was excessive tremulousness was there, and this is a non-epileptic event. Another patient, you can see the epileptic on the one side, and on the second side it was a non-epileptic event. Does not match with some classical presentation of the semiology of any seizure type. You can see, and it was more when the audience was there. You can see, and if the child was left alone, nothing happened. So this is a classical non-epileptic event. Another patient, you can see that the tightrope walking, tripping propulsion with fall is there. Yeah. These are all non-epileptic event. See what she is doing is that this. See the abnormal family interaction was there. So very, very important is that non-epileptic, and they try to remember rule of 2. Onset after the age of 2 years, seizure duration more than 2 minutes, occurrence with more than 2 witnesses. This is again important. If 2 or more criteria are met, you are 85% predictive value that you are dealing with the PNS. So rule of 2 distinguishes, you can see the another one. Distinguish drama from the disease. That is again very important. Another patient, you can see the non-epileptic event. See the he is having a jerk, similar sort of myoclonic jerk as the video number 2 female patient exhibiting. She was a case of classical juvenile myoclonic epilepsy, and the way the jerk was there in the video number 2, just see the jerks in the video number 1, and upon asking history, very important, and this is the polyspike discharges from the now see the history. See the naughty smile of this patient. Variability, suppressibility, entertainability, this is all favoring the non-epileptic myoclonic. See, this is the tonic sort of seizure, and the second non-epileptic event, second video was saying that there is a tonic posture after he had a fall on the floor. There was a circumoral cyanosis, classical of breath holding spell. You can see that this is a classical presentation, tonic sort of spells mimicking the tonic seizure. Just observe the circumoral cyanosis. This is a breath holding spell. So if this is a cyanotic spell or it is a the pallid spell, this is a very important. Take EEG, which will give you a direction that you are dealing with a cyanotic one or a pallid one. So when anger turns blue, think cyanotic. When fright turns pale, think pallid. So just to differentiate cyanotic spell and the pallid. Another patient, see the tonic spasm of the, just see that. Both the patient having or frequent episode disappears during sleep. This is a classical infantile gratification phenomena child is exhibiting. And mind you, this is a condition which can mimic any sort of semiology. You will see that not every wiggle is a seizure, sometimes it will. Now see, tonic posturing, adduction of the thighs are there. You can see these are all the videos sent by the parents as well. So pelvic thrusting and rubbing, you can see all sort of. So these are the videos sent by the parents. So it gratification phenomena imitates any sort of etiology. That is that to be remembered, and you have to counsel adequately. The very parents are very disturbed, and this is the strategic parental education, behavioral guidance, environmental modification like that. This is classical. I will go very fast. This is classical presentation of shivering sort of episode. What is this known as? The shuddering attacks. You are seeing this is the classical shuddering attack, a benign sort of movement, as a no treatment is required. And these are the all videos exhibiting shuddering attacks. Just see the videos. You will never forget in your rest of your life that you have missed any sort of shuddering attacks. You are these. Another another patient with arching after meal, we immediately pick up that probably there is some sort of G reflux is there, and the Sandifer comes into mind. So arching with meal may be a reflux and not an epilepsy. And non-epileptic arching is usually prolonged, and it is related with the meals as well. So the managing principle, accurate diagnosis before anti-seizure medication, because these are the non-epileptic condition we have just discussed. Most of them we are loaded with the anti-epileptic drugs. So our approach should be, our approach will be not to load anti-seizure medication when it is just not required. Parental counseling, benign nature of the mimic has to be counseled. Counseling is very important. Referral to pediatric neurologist. Always, when in doubt, take consultation with your friend, colleagues, pediatric neurologist. So first, do no harm. Don't start anti-seizure medication till you are very sure. So take home message are careful history, very important. Home video, very important. Combining two, you are almost near to 80% diagnosis. Red flag of epilepsy has to be in the mind, and key clues has to be taken care of. So, friends, the child is a chapter, the parent the page. Together, they teach us at every stage. Thank you, all the parents and their children for teaching us. We are a lifelong learner. So, friend, this was not a Amitabh Bachchan. He was a seizure mimic sort of thing, or look alike. He was a Shashikant Pedwal. Thank you so much.
Thank you so much for such a great presentation, sir. So we got a chance to see so many videos which demonstrated the problems which we face in our day-to-day practice with these seizure mimics. So thank you so much, sir. For the third talk of this series of Masterclass in Pediatrics, I request Dr. Vilas Zadov, sir, and he is going to speak on diagnostic approach to seizure disorder with a focus on recent updates. So the stage is yours, sir.
Is my screen visible?
Yes, sir.
Yes, sir.
Thank you very much. Thank you, Dr. Sanju Joshi, sir, all scientific committee members, office bearers, and executive board members. Thank you, my previous speakers, for making my job bit easy, as I don't have to talk about epilepsy syndromes and non-epileptic events. Thank you, Dr. Anup Verma, sir, for excellent talk. Dr. Vishwanath for excellent talk. Thank you all joined delegates who found the time and being with us. So today, my job is to tell you the approach to seizures in children. So this is a dummy case where you have an 8-year-old boy who had a fall and loss of consciousness at school. He vomited once after the episode. Teacher calls up his parents, and by the time mother reached there, she found that he was back to normal with no signs of trauma anywhere. So he was perfectly fine when he left to school in the morning. So similar kind of situation you will find in your office practice. And the first thing when you approach this kind of scenario is get the detailed history from the first hand witness. You need to talk to the teacher or whoever the first hand witness. If parents they don't witness the episode, your job is just call, spend few minutes and talk to the first hand witness. So what do you want to ask? Obviously, what was the situation when the episode occurred? Suppose child is standing, as Dr. Anuparma said, he's standing in the prayer for too long and he gets the episode, likely to be syncope rather than seizure. So which setting it occurs? What was the behavior prior to the event? Was he very tense? Did he have some aura? What was the behavior during the event, actual event? That's the first hand witness will tell you that actually, well, his eyes were turned to right, whatever it is, and hands were shaking and all. And what happened after the event? Did he have postictal aphasia or did he have postictal deficit? Did he vomit? So everything you need to know as a pediatrician to come down to the diagnosis. So of course you need to go for any similar episodes in past, and what is developmental history and what is a family history. When you examine a similar case, the first, if you find a positive clues like, you have some hyperpigmented or port wine stained, whatever it is, then probably you know that this is likely to be a seizure. When you have a child with a dysmorphic features, likely to be a seizure, not always. Again, intellectual disability, say autism and all, likely to be seizure, but not always again. If you have classic pyramidal dysfunction, likely to be seizure. So how do you approach? First thing is it really non-epileptic event? Mind well, a children who already have epilepsy, proven on imaging or whatever on EEGs, may have a non-epileptic event. Be careful. Is it a really seizure or is it epilepsy? So non-epileptic event, Dr. Verma sir has already clarified in lots, so I don't have to talk about it. Let's talk about definition of Vishwanath has already said that seizure. Seizure means it's a clinical expression of abnormal excessive synchronous discharge of neurons. Word acute symptomatic seizure is a provoked and a reactive seizure which occurs after either acute systemic illness, could be hypoglycemia, hypocalcemia, hypotension, hypoxia, whatever it is, or a brain insult itself. And one more terminology you need to know when you are dealing with approach to seizure is a reflex seizure. Reflex seizure is usually evoked, not provoked. It is evoked by external stimuli like sound sensitive, touch sensitive, or maybe internal stimulus like emotions or thought. Epilepsy, Dr. Vishwanath has clarified this. I don't have to tell you about that. These are two unprovoked seizures which occur more than 24 hours apart, or a single unprovoked episode which has a probability of getting high, more than 60% chance of getting seizures. Again, a classic example is a previous insult, and only one unprovoked seizure. And you have obviously diagnosed epileptic syndrome, even one unprovoked episode falls into the criteria of epilepsy. So next question you should ask when you approach the child with, now we are dealing with only seizure, not non-epileptic, a seizure disorder. So what type of seizure is this? Oh no, this is very important. The famous cartoon Vishwanath has already shown you is the seizure types are focal, generalized, and with unknown onset. So let's talk about seizure types which are classically focal. What does focal terminology mean? Means the seizure is either limited to one side of the body or it originates into the one of the hemisphere. It originates and stays into the one of the hemispheres. Whether it can be electrographically, it can be clinically. Then next thing, when you know that, well, this is a focal seizure, was it associated with impaired awareness, that is impaired loss of consciousness, or it is not? So depending on that, you can subgroup the episodes. Let's see. So this girl, you can clinically see that her right hand and right limb is rhythmically moving and she's aware, she's talking.
Shravani?
Yeah, she's responding. So this is one side of the body is involved, so it's a focal. Rhythmicity, as Dr. Anuparma has already said, it's a clonic seizure. It's a focal clonic. Because she's aware, it's a focal aware clonic seizure. This boy, on the contrary, has gaze and head deviation to right. There is a rhythmicity in the right hand. That's a clonic jerk. So this type of seizure, he is not responsive. So this is focal unaware clonic seizure. Next thing, there was a motor seizure. You can have a sensory seizure. So you can have somatosensory. Child can have a unilateral pain, unilateral numbness, you can have only visual sort of seizure, like you can have micropsia, macropsia, lots of bright colors, whatever, abnormal colors. So abnormal taste, abnormal sound. So it's called as a focal but sensory. The previous one video I showed is a focal motor. This is focal sensory. Now you can have a non-motor. Now you see this girl just stares. Non-motor means there is a motor arrest, but you can have a ical automatism in that. So these are called as automatism, where the child tries to, has circumductory movements or a semi-purposeful movements of the hands. So these are the automatism. These are not clonic or tonic movements. They are the automatism, semi-purposeful movements. So this type of seizure is called as a focal non-motor or with automatism or a dyscognitive type of seizure. Another why it is important to know that whether it's a focal or whether it's a generalized or whether it's a tonic or clonic. Yes, you can choose the drug appropriately. So the approach differs with the focal seizures, differs with the generalized seizures. So this focal seizure can be affective. Affective means there is lots of emotions. See the first boy, he just laughs without reason. You can note his hyperpigmentations also. So this is called the laughing seizure. This is a gelastic seizure, usually common with the hypothalamic hamartomas. So that's a laughter or laughing seizure. It's an affective seizure. It's a focal affective seizure. So they're called as a gelastic seizure. And the second girl here, lots of fear. You can have a hypermotor kind of thing. Still, it's a focal. This is not generalized one. There's a fear on face, and she has a hypermotor kind of seizure. So focal seizure may look clinically involving both sides of the body. You have to be very clear before labeling that this is generalized or this is a focal one. Then there is another type of focal which is called as a focal to generalized. It starts on the one side. You can see left side of the body is rhythmically jerking. There is a clonic movements of left upper limb and left lower limb, which lasts for a few seconds or few minutes, and then child turns head to the right, and the opposite side also is involved. So it starts on the one side of the body and moves to the opposite side. It's called as a focal. It still is a focal. You can miss the onset. You can falsely label this as generalized one, but it is still is a focal one, which starts on the one side of the body. So that ends up your focal. Focal can be, as I said, it's a motor, it can be somatosensory, it can be affective, it can be focal to generalized one. Now come down to the generalized seizure. The concept of generalized seizure, it originates bilaterally, it stays bilaterally. It starts at the one go. Practically, there is no seizure which starts, generalized. It has to start somewhere else, but the spread is so rapid that it gives you the impression that it's a generalized one. Here, usually you don't have a generalized seizure without loss of awareness. Always, all generalized seizures will have an impaired awareness. You can have a subtype of generalized seizure. This is called a generalized tonic. As I said, generalized means it has to be onset, has to be on the both sides. See, that's both upper limbs, upper limb of eyes are stiff. So this is a brief generalized tonic seizure. Generalized clonic seizure, again onset bilateral clonic, rhythmic movements. Generalized tonic clonic, see child is undergoing photic stimulation. So look at the onset. Bilaterally, symmetric, both lower limbs, both upper limbs. Initially, you saw that there are few arrhythmic myoclonic jerks. Then there is a diffuse tonic posturing of both upper limbs, both lower limbs. This is called as a generalized tonic to begin with. Soon, the clonicity sets in. There is a bilateral rhythmic clonic jerking. So started as a myoclonus, but then tonic seizure, then the clonic one, and then the stage of flaccidity. So that's called as a classic generalized tonic-clonic seizure. Then generalized myoclonic. Myoclonic difference between clonic and myoclonic is arrhythmicity. Clonic seizure is very rhythmic. Here there's a very brief duration, shock-like. See, there's a very brief one. Shock-like jerks. That's usually myoclonic. Clonic is usually rhythmic. Jerks are not very short duration as this myoclonic. Myoclonic is it's a shock like very brief. Clonic is little prolonged and a rhythmic one. So this is a myoclonus one. Atonic is a sudden loss of body tone, muscles, usually flexor. You can have extensor atonic anywhere, So it's a atonic falls, atonic drops. Atonic falls are usually generalized. Absences, Dr. Vishwanath has already shown, Dr. Anuparma has also shown, hyperventilation. There is a brief loss of consciousness, bit of eyelid flickering, little loss of body tone, does not fall down, does not respond to the verbal commands. The episode lasts for a few seconds, and again, child returns back to normal. Now, very difficult. Now, how do you clinically differentiate this from a focal unaware seizure? Focal, as I said, non-motor focal unaware seizure. I showed you the video. I showed you the absence video. Number one differentiating feature is usually absences are never seen in less than 3 years of age. So if you see a child who is just staring, absent from the surrounding, who is a less than 3-year-old child, is unlikely to be the absence, number one. Usually seen after 3 years to 4 years of age. Number two, all absence episodes are very frequent. You don't have absence seizures one in a 1 month, one in a 2 month, one in a 3 months. No. When you have a child who presents with a staring episodes, which are very frequent, 50 episodes, 100 episodes a day, is likely to be absence. One episode every month or 2 months is likely to be a focal unaware seizure. And number three is obviously, you can precipitate the absence with a hyperventilation. Now, once you know the subtype is unknown onset seizure, where you can't clearly determine whether the onset is generalized or focal. Sometimes it's a focal, sometimes it's a generalized. Classic exam, no, it's not atonic. It's falsely written here. It is called as epileptic spasm. Sorry for that mistake. So a classic flexor, back-to-back, sustained contractions, preceded with little myoclonus, and then followed by sustained contraction is a classic example of the epileptic spasm. How do you clinically differentiate myoclonus from the epileptic spasm is, if you see this, with brief sudden, after that there is a sustained contraction. When you have a sudden brief jerk followed by a sustained contraction of body, it's likely to be epileptic spasm. Usually spasms come in the series, 1, 2, 3, 4. Myoclonus unlikely. So that's the clinical differentiation features between epileptic spasms and a myoclonus. The sustainability following myoclonus is likely to be epileptic spasm and coming into the series. Next, the question you need to ask once you are sure that this is this particular type of seizure, this is a type of seizure first, and this is this particular type of seizure. Next thing, is it fitting into epileptic syndrome, which already Dr. Vishwanath has dealt in very clear. I don't have to do it again. So I'll talk about the brief algorithm of approach now. Once you know that this is a seizure, this is a type of this seizure, this is a type of epileptic syndrome, how do you deal with this? Now, first thing is a seizure is provoked or unprovoked. If it is provoked with a fever, obviously you need to think of three possibilities. It is a febrile seizure, Is it a febrile seizure plus or is it a Zep's plus spectrum? Okay. Difference between, already I think you know, I don't have to tell you, but febrile seizure classic age group 6 months to 6 years. Febrile seizure pluses usually more than 6 years of age, or afebrile seizures following febrile seizure, and Gibbs pluses there is a positive family history with the FS plus spectrum. Second provoked seizure is you can have meningoencephalitis infections, you can have post-infectious like edema and all with a seizure disorder, with you can have HIE, you can have a trauma causing seizures and a brain injuries, you can have transient metabolic events which can cause as a seizure as an acute symptom. They are not epilepsy, they are acute symptomatic seizure. You don't have to continue anti-seizure medications for lifelong. So you need to see that is it a provoked one or is it an unprovoked one. Now let's go for a major chunk that is unprovoked seizure where you are seeing with whether it's a really epilepsy or not. So how do you deal with this? See the child, whether see the neurological status of the child. If it is abnormal one, well, this is likely to be a symptomatic epilepsy, symptomatic seizure. If you have a clinical detail suggestive of, insult in the past, maybe HIE, maybe hypoglycemic, maybe a meningoencephalitis in the past, obviously, then you do imaging, likely to be this is termed as a remote symptomatic epilepsy or seizure. When you have a dysmorphism as a abnormal example, like this is called as a syndromic delay with seizures, or some of the malformation of cortical development, say lesioncephaly, so Miller-Dieker syndrome, they have present with a dysmorphism and a intractable epilepsy. A child who has abnormal neurological status with a regression, initial child was normal, but after the seizures, the child is regressed and there is an intermittent deterioration interactability with a normal imaging. This is likely to be a neurogenetic or neurometabolic disorder. Now, a child who has unprovoked seizures or lots of the unprovoked seizures like epilepsy, and you have a normal neurological examination, how do you do it? As I said, first thing is determine the type of a seizure. If it's a focal seizure with a clinically normal child, I'm not talking about now abnormal child, I'm talking about a completely normal child with a focal seizure, think of two possibilities. Ask whether the seizure occurs in awake state. If seizure occurs in awake state, completely normal child, it is a focal seizure. Whether in India, think of cysticercosis first, look for the clinical details. If the clinical details are suggestive of a benign epileptic or a self-limiting epileptic syndrome called as a COVE, occipital visual epilepsy, classic clinical scenario, EEG is classic. You don't have to imaging the child, only do EEG study. If clinical details are suggestive of, not suggestive of visual epilepsy, probably you are dealing with cysticercus, you have to do imaging. So a child who has a normal neurological examination, who has a focal seizures in awake state, two possibilities. It still could be a symptomatic seizure, but where you may not have a classical clinical details suggestive of COVE, do imaging. Clinical details suggestive of COVE, do EEG. A child who has a normal neurological examination, focal seizure in a sleep state, likely to be a self-limiting epilepsy syndromes, first do EEG. If EEG is suggestive of either selects celiac self-limiting epilepsy with autonomic seizure, it's called as a panayotopoulos, or it is self-limiting epilepsy with a midline spike, that's called as a vertex spikes, then you made the diagnosis of epilepsy syndrome. But if it is not suggestive of any of this, please do imaging. Probably you are missing with a symptomatic epilepsy. That's a clear one. A focal seizure. How do you deal with this? This is how the algorithm you should go follow it. Now come back to the generalized one. You have a normal child. You have a seizure with a generalized onset, not a clear-cut focal onset. Now, how do you deal with? See whether that generalized seizure was preceded with the past history of febrile seizure. If yes, there was a past history of febrile seizure, child is clinically normal, child has now generalized tonic-clonic seizure, get an EEG study done, probably you are dealing with either FS plus spectrum, ZEBS plus spectrum, or a GTC on awakening, whatever it is. As I said, if it's on awakening again with this past history of febrile seizure or may not be, then EEG study, probably you are something called as a GTC seizures on awakening. then there are no clinical cues. Generalized tonic-clonic seizure, child is normal, but there are not suggestive of nothing. Probably along with EEG you need to image, because probably you must have missed the focal onset. Do both together. Probably you should not miss a symptomatic one. Now, the third seizure type, a child who has a normal neurological examination and absence type of seizure, probably you don't have to do imaging here. You have to do EEG classical. It can be childhood absence epilepsy, depending upon the age group. It can be juvenile absence epilepsy. It can be juvenile myoclonic epilepsy. If the generalized seizure is a myoclonic one, again, EEG study in a child who is completely normal. If it's abnormal, do imaging also. If completely normal child with a myoclonic seizure as a seizure type, do EEG first. Probably you are dealing either with a juvenile myoclonic epilepsy or a benign myoclonic epilepsy of infancy, depending upon the seizure type, age group type. If you have a generalized seizure with epileptic spasm, always do EEG plus imaging. Probably you are dealing with a West syndrome. EEG and MRI is missing. MRI should be done in all epileptic spasm, even if it is cryptogenic one. If you have atonic seizures as a seizure type with a normal neurological examination, although you do EEG along with that, I would also recommend to go for imaging too, because most of the epileptic syndromes are the symptomatic one with the atonic falls. There is only single epileptic syndrome which is called a self-limiting epilepsy with the midline spike, which can come up with atonic seizures. If you have done EEG and you suggest you have midline spike and atonic falls, probably you don't have to image it. But rest, LGS and myoclonic astatic epilepsy, you need to image it. So, unprovoked seizure with a normal neurological examination, the second clue apart from a seizure type is a setting in which seizure occurs. What is the setting? If it's very nocturnal one, absolutely nocturnal, EEG, you may be dealing with selects and autosomal dominant nocturnal frontal lobe epilepsy. If it is very early morning, as I already told, apart from GTC on awakening, there are two more conditions you must, as a pediatrician, aware of. One is a hypoglycemic episodes. A child who is clinically normal, the development was normal, recurrent early morning episode, usually prolonged. The difference classically early morning seizure, if it's very short lasting, likely to be GTC on awakening. Very long lasting, 30 minutes, 40 minutes, till he is hospitalized, lots of sweating, lots of myoclonic jerking, likely to be hypoglycemic. Hypoglycemic seizure unlikely to remit on its own unless child receives something. So keep this in mind, clinical clue that prolonged early morning seizure likely to be hypoglycemic. Always do blood sugar levels. If you have, a normal child, especially infant, and you get a generalized or whatever, usually generalized seizure, always ask history of camphor. Most of the time, normal child, clinically normal, infant child, unprovoked, the first seizure, always ask for history of camphor. Probably it's called as acute symptomatic seizure. I think that finishes the clinical approach, and this is not a talk for today. So I end up here. Thank you very much.
Thank you, sir, for that elaborate presentation on the approach to the seizures. And I now hand over to Sachin for the further proceedings.
Yeah. Thank you, sir. Now I request Dr. Vinit Wankhede for
Yeah.
regarding the experts' comments.
Yeah. Thank you, Dr. Sachin and Dr. Sanjanatu sir, for excellent moderation. At the outset, I want to thank Dr. Joshi sir. When the thorough academician became a president of any organization, such academic program should be a kickstart. So, a fantastic academic show. So, I'm very happy that neurology was the first, because he was a past chairman of AOPN also. So, we're very happy that the first platform was given to the neurology. Thank you so much for that, sir. So you have heard three talks. I think seizures, epilepsy is a important subjects, and you day in day out come across these cases. Issue is as a pediatrician, there are only 5 6 questions which need to be answered. First, am I dealing with the seizures? And for that, First thing is to rule out the seizure mimics. And who can tell us better teach than Dr. Anup Verma sir? I think he can teach us better than ILE with his profound knowledge and thorough experience over last 30 to 35 years. He has shown beautiful videos of how to rule out those seizure mimics. I think I can't say much more than that. He is an excellent orator, and you have seen all those videos. Second question is about the clinical diagnosis of the seizures. So now ILE are classified and they keep on classifying. Sometimes we feel that ILE make our task very difficult because they have like 100 types of epilepsy syndromes, epilepsy and these all things. But recent one, 2025, they had a recent edition where they earlier made it a summarized classification. Like earlier they had 63 types of seizures, now there are 21 types of seizures. And the way Dr. Vilazado sir, if you heard that last 10 minutes, I think that's where the take home. Beautifully has told the seizure types, at what time they are occurring, and so first to identify the seizure type, how they look, that also he has shown through the different videos, and how, at what time they appear, during seizure, during nocturnal or on awakening or during the daytime. And these are the important features which tells you what how to evaluate further. Thank you so much, Vilas Dado sir, for that excellent talk. And third thing, whether to see whether they fit into an epilepsy syndrome, because epilepsy syndrome is a terminology where we want to constill into a one syndrome where which has a fixed etiologies, which has a fixed type of seizures, which has a fixed prognosis, which has a fixed treatment plans. So I really make your task easy, not difficult. We feel that it's making difficult, but it leads to a tailored approach. Like usually we have 5 6 questions when such patients comes to us, like whether to go for an EEG or not, whether to do a neuroimaging or not, when to consider the metabolic epilepsy, is it a genetic epilepsy or not, because so many labs are approaching you that this is the genetic panel, this is the epilepsy panel, and we often get confused that whether it's likely to be a genetic epilepsy or not. So some benign epilepsies are also genetic. It's not key only the drug refractory epilepsies are genetic. So those questions, if you try to categorize into a epilepsy syndrome, it becomes very easy for the pediatrician or the clinician to go ahead with the selective investigation and use a tailored approach. Fourth question is whether to start an anti-seizure medication. Now they have also made the choice of the antiepileptic. So we are not going into the details of the treatment modalities, because as a clinician, first responsibility is to diagnose it correctly. And often what we have seen that epilepsy is sometimes overdiagnosed. And I will give you a reference. There is a beautiful paper from Sri Chitra Hospital in I think 2014. They have published a paper because Sri Chitra is a tertiary care institute for considered for the epilepsy surgery. And the total number of epilepsy patients, so they have reviewed last 10 years patient. So they are total almost 17 1800 patients which they have got as a referral as a cases of drug refractory epilepsy. And when they evaluated whether they are really drug refractory or not, whether they are surgery amicable or not, what they have found that one third of the patient, almost 35 to 40% of the patient was never had an epilepsy. They were seizure mimics. So the nocturnal epilepsies, nocturnal events, or so many seizure mimics, Dr. Anup Verma sir already talked about, were diagnosed as a drug refractory epilepsy and started on n number of anti-seizure medication. So to that way, if you see a clinical practice, sometimes it is overdiagnosed. What even the literature suggests that. So our job is proper diagnose, avoid overdiagnosis, do not do underdiagnosis. So I think this previous three speakers have made our job very easy through their excellent lectures. And the fourth, fifth, last question is when to consider metabolic epilepsies and the genetic epilepsy. So any child with epilepsy where you have an inconsistent MRI, we have a decompensation with the febrile illnesses, which fits into a specific genetic epilepsy syndrome where you have uh, genetic etiologies with a fixed etiology of that syndrome, then you should consider the or the all the cases of the refractory epilepsies or the developmental epileptic encephalopathies. We're not going into that details, but those are the subsets where we need to do a genetic evaluation. I think all the speakers were so fabulous, and including Vishwanath, who has already told about the important epilepsy syndromes, what we see in the practice, like Rolandic epilepsy, what we call it as a SILEX now, and the West syndromes and the absence epilepsies. At least this prototype epilepsy syndrome must be known to pediatricians uh, to make the job easy. So it's always get it done from a proper pediatric neurologist, because the erroneous reporting is one of the most important thing in the practice. So if you don't do it a proper epileptologist or a pediatric neurologist, the chance of underreporting, overreporting, underdiagnosing, overdiagnosing is very high. So make sure that you send to a proper pediatric neurologist or a proper qualified epileptologist with the clear instructions. Like suppose if you are an absence epilepsy, always ask for HV, hyperventilation. If you don't write on that thing, that is going to get different results. If you don't do a sleep result in a Rolandic epilepsy, if you don't do ask for a sleep EG, if the setting is like office, suppose like a technician is doing and he is busy and he is doing in awake state, then the chance of finding that important diagnosis of having a sleep discharges only in sleep will be missed. So those all practical points are very important in diagnosis. And I thanks again all the organizers, all the office bearers of Maharashtra IP, Renu Madam, Joshi sir, Dr. Sachin, Dr. Nathu sir for excellent moderation, Dr. Ramakant Patil, Dr. Amol Pawar, and all the office bearers for giving this opportunity. Thank you so much. And all the audience who have been listening, I am seeing the numbers is always 250, around that. So they are given the 10th is already 10:30, and I think only 2 3 have left. So thank you so much for being such a nice audience. Thank you so much.
Yeah. Thank you, Vinesh sir. Now I think the forum is open for questions. If some questions are there, anybody can. Yes, please unmute and you can ask question directly also, or put in the chat box. At least for more.
I think chat box is full of
Chat.
MMC
Yeah,
numbers.
registration number. Questions are not there. Okay. Anybody want to ask any questions?
So we am
Okay. No questions. Yeah. So now it's time to wrap up the
there are a few
academic
comments about
session.
being nicely explained.
Yeah. Uh, I extend my heartfelt thanks to all the esteemed speakers, Dr. Vishwanath sir, Dr. Vilas sir, Dr. Anup Verma sir, Dr. Vinit, for sharing their valuable knowledge and practical insights. Surely your sessions truly enrich us. A special thanks to our Maharashtra IP President Dr. Joshi sir for his inspiring guidance and constant support for the academic activities. A thanks to our MMC observer, my co-moderator Dr. Sanjay Natu sir, and all OBs and EBs of Maha IP and Central IP for the support. My sincere thanks to all the participants who joined us today, who made this session interactive and lively. Almost more than 250 delegates was there. So at last, this program marks a strong beginning of the Maharashtra IP 2026 academic journey, and we look forward to many more enriching sessions ahead. So, good night, all. Now you can sign
There is,
off.
no,
And
there is one. Priyal Shah is probably wants to ask something. Can she ask?
Yes, sir. It was regarding convulsive
yes,
epilepsy. Can you tell us
इसको
a little
बोलना
about convulsive syncope? Sorry, convulsive syncope.
Well,
हाँ बोल बेटा
syncope can have uprolling of eyes, can have tonic movements, can have clonic movements, can have tonic clonic movements, can have bladder incontinence, can have vomiting also post event. So exactly the whatever seizure components are there can be seen with syncope if it's a little prolonged one. Not always, you will get only a limp. You can have a tonic posturing clonic movements. Now, how is it? This is called as a convulsive syncope. It's a non-epileptic event. It's like a breath holding spells, having uprolling, having tonic posturing, having few clonic jerking. So how do you differentiate clinically is it's a precipitating factors. It's a pre-event things which tells you that, and as Dr. Anup Verma sir has already said, there is usually pallor prior or maybe during that episode. Most of the time is sweating. So the pre event description and the history is very important to differentiate from epilepsy. Although it looks like a seizure disorder, actually. I hope that solves your query.
Yes, thank you so much.
No more questions, I think. So, good night, all.
Yeah,
You
good
can
night.
now sign off, and now I officially declare the end of today's webinar.